CODAC Behavioral Health Care has been very fortunate to have many advocates in our continuous fight with the opioid overdose epidemic, but certain individuals stand out. Not only have our advocates understood what we're up against, but also more importantly, what the people that come to us for care are up against. These advocates have also delivered for us services, necessary services, both statewide, regionally, and nationally. I'm honored to be here at CODAC Live with Senator Sheldon Whitehouse. You've not only been a tremendous partner for CODAC, but you've been a tremendous advocate nationally. Can you describe to us a little bit of your history from when you were in the Attorney General's office to wherever else you have gone in terms of your understanding of the disease that we treat?
Well, I think I started working with you in the advocacy community back when I was working for Governor Sondland. And we were putting budgets together and working on legislation. But the first really notable move I was able to make was when I was elected Attorney General and was able to shift the position of the Attorney General's office from opposing a drug court to enthusiastically supporting a drug court. And with that, the drug court was launched with a lot of support from Judge Rogers.
Yes.
Joe Rogers then, the chief of the Superior Court, and the various judges who've supported it since then. So I got an early start back then, understanding that there are better ways to deal with addiction and recovery than prosecution and incarceration.
Yes. And it's interesting to me that we don't have to say that as many times now as we did then, but we still have to say it.
Yeah, it's still, unfortunately, it still needs to be said. But anybody who has been to a drug court graduation, as opposed to a criminal sentencing, it's an unforgettable difference. A drug court takes the power, as you know, of the judiciary, and instead of using it to convict and incarcerate an individual, uses it to set guardrails for a pathway for them to recovery. If they fall off the pathway, they've got to come back to the court and explain themselves. If they persistently fall, well, then they may go back to the original prosecution and incarceration mode. But at least it gives a very strong, powerful exit ramp for people to get into the treatment that they need and avoid the burden on the prisons and the law enforcement side.
And at this point, this is truly evidence-based.
Oh yeah.
What was initiated is proven to work, proven.
Yeah.
Yeah.
We had good support from Brown and others with the support for the concept initially, but nothing actually succeeds like actual success. And the record of the drug court is phenomenal, and it's now expanded so that there's a mental health court.
Would you like to tell us a little bit about the Comprehensive Addiction and Recovery Act?
Sure. This was the first major bill I worked on in Congress on addiction and recovery. I knew it had to be bipartisan, so I worked with a Republican colleague, Rob Portman, who is from Ohio, which had a terrible footprint of overdoses, a little bit like ours. And so we had common cause there. And then we put a lot of work into preparing the law with national conferences that we brought people in from the health sector, from the law enforcement sector, from recovery programs, and to make sure that we had a really robust bill and a lot of advocacy support for it. And so at the end of the day, when we filed and pushed it forward, it got a very good reception. There's always a bit of hesitancy on the Democrat side to pass a bill that will be good for a Republican like Rob Portman. Mm-hmm. And there's always a bit of hesitancy on the Republican side to pass a bill that would be good for a Democrat like me. But this was such an obviously needed measure that we were able to blow through those hesitancies and get the bill passed with a very strong bipartisan vote in the Senate. And then with it done in the Senate, it was short work in the House to get it passed into law.
What I loved about, as from a provider perspective, what I loved about the work that you both did on this bill, and your staff were amazing, was that it was comprehensive.
Yeah.
That wasn't just a word to make up a good acronym.
Yeah.
It was totally comprehensive, and I have so much appreciation and gratitude for that. So CARA 2.0, can you tell us a little bit about?
Well, CARA 2.0 sort of followed up on CARA with money. So CARA was the authorizing bill that allowed a whole bunch of programs to be started. Most significantly, for the first time, it put congressional interest behind the recovery part of the process. So it was a very big deal, but it really matters a lot when the actual money comes through. And CARA 2.0 brought in, I want to say, $750 million. Yeah.
Moving forward, Senator, what do you see as the biggest barrier to providers, well, to all of us as we work as a team, turning the tide on this epidemic?
Well, I think there's still some lingering instinct towards punishment rather than treatment, although much less. I think that there is still considerable lingering stigma, although again, much less. And then there's a major resource issue with supporting the people who do the work of providing the treatment and the care for people who are getting out of addiction and through recovery.
Well, I agree with that. We have a tremendous workforce issue, tremendous. And so across the nation, but here in particular in Rhode Island, we have individuals who have been with an entity, say, for 20 years or 30 years even. There is a piece of compensation that is, I think, reflective of the historic stigma. We are overregulated and undercompensated due to basically institutionalized stigma. And so Rhode Island has the fourth lowest rate in the country for Medicaid treating these diseases, but we have the 8th highest rate of per capita overdose death. And so it's very difficult for me as a provider to be able to reconcile those two things.
Yeah.
It's very difficult. Can you see any way that would help us reconcile that? Because it's a huge disparity, and it flavors every single thing that we do all day long.
Well, the CARA money coming in has supported groups and allowed them to get additional resources, so that has been helpful. I think Medicaid reform in Rhode Island is a work in progress, but progress will be signaled by better compensation for mental health, behavioral health, and addiction work. I think the backstory here is actually quite a good one, and that is that the people who come to this work come to it out of a feeling of love and mission and passion, and are willing to be underpaid. But that doesn't mean that it's fair that they should be
And it
underpaid.
doesn't hold.
And it doesn't hold over time.
No,
Exactly.
because I need a home, I want children, I want to pay off my student loan. So we see it happening, that being a bit eroded.
Yeah.
The altruism is eroded a bit sooner than it used to be.
Yeah.
It's just a challenge that we're facing. And our legislators have been actively working. Senator, how do you believe that we could educate general population across the board, across the country, but in particular here in Rhode Island, better educate people around what is this disease, what is the epidemic? And we have been struggling for decades to get that information out there, because we know that stigma is this small little word, and it's fear, it's bias, it's prejudice, and ultimately discrimination. And it permeates every aspect of a person's life or an entity's life. So how would you see us changing, becoming more effective with the messaging we're doing?
I think the best messaging is success.
Yeah.
And every person who recognizes their addiction, moves into recovery and rebuilds their lives has enormous impact on all the people around them who see that transformation. And I think when you see treatment and recovery working, that's the strongest message of all, because it comes through to the people who are the loved ones and the kin and the friends of the individual involved, and it's very meaningful when it's someone you know, when it's someone you love. You can't beat that. So making sure the resources are there, making sure the programs are there, making sure the successes are there, I think is our very best strategy.
I think from the very beginning, both Michael and I, the board of CODAC, the senior leadership and counselors of CODAC, all agreed that the individuals that were coming through the door deserved a level of treatment that would prove to significantly improve their lives forever.
We always felt that the drug part was just the tip of an iceberg. Every time CODAC did something new, it was because there wasn't something there before. CODAC was the first not only to be an general outpatient program, but the first intensive outpatient program and the first day treatment program in Rhode Island.
That behavioral health part of having a counselor is definitely needed with the medication. My counselor has become my best friend. She's pushed me in the right direction. She's told me when I was wrong. I almost didn't go. I really almost did not go to treatment. And I wonder today where I would be if I didn't.
The mission of CODAC is providing the comprehensive care that is needed by those that come to us for our services for them to enjoy recovery. As we have grown, as we have realized the intersection of science and service, we have been able to provide more and more care for those that have opioid use disorder. We began providing psychiatric care. We began providing specialty medicine care. And then as we've moved on and evolved through the leadership of Craig Stenning, then through Mike Rizzi, we continued to add services that reflected the needs demonstrated when someone came in for care. Now we provide primary care and we provide specialty medicine in the form of a full infectious disease program. We provide psychiatric care and mental health care, and we also have what is called OTP, Opioid Treatment Program Health Home. Childcare, transportation, all those different external, so to speak, issues that people face that get in the way of them being healthy.
We saw substance use treatment as a professional part of the medical community. To the credit of CODAC, it didn't go away after 10 years or after 20 years or after 30 years, and here we are after 50 years. I can proudly say that I'm thrilled with where CODAC is today and where it will be in the next 50 years.
CODAC Healthcare today does what we refer to as fully integrated healthcare, because this disease is a highly complex disease, and this is where we started. You know, we are the expert, and I'm proud of that, in the treatment of opioid use disorder. But this is a biological, a sociological, a psychological, a spiritual disease. It erodes people's souls. It's a very, very degrading disease. And so in order to heal from it and really enjoy a recovery, we have to address all of those aspects. So today what CODAC does is, of course, we treat opioid use disorder and other substance use disorders. We do it with therapy, we do it with medicines, methadone, buprenorphine products, naltrexone products, and also, you know, the products that are available for alcohol and other substances. We provide primary care now. We provide psychiatric and mental health care. And as we move into our larger facilities with more capacity, we're going to also be able to provide all the social service networks that people need in order to get their basic needs met and then flourish.
You mentioned that this is the first in the country, and this isn't the first for CODAC. In fact, CODAC's been a pioneer. Can you describe some of the CODAC firsts?
Well, the medication-assisted treatment in the Rhode Island Department of Corrections is an internationally known first. And what that means is medication-assisted treatment. So we were providing medication-assisted treatment in the prison for opioid use disorder. And so we were providing, and this is where the first came in, methadone, buprenorphine products, and naltrexone products, which is commonly known as Vivitrol. It's an injection that is often used for the treatment of alcohol use disorder, but also has been found successful in certain populations with opioid use disorder. So we're providing all the medicines to all people that need them when they are committed to the prison. And that is huge because there are other prisons, other jails, other correctional facilities in the country that will provide the medicine. If someone was in a program utilizing methadone in the community, they get arrested, they get committed, they're sentenced. Many jails or prisons will keep them on their medicine, just like they keep them on their medicine for heart disease or any other chronic disease. But we allow, at the Rhode Island Department of Corrections, anybody that needs it can have it. So if you come in withdrawal, if you are committed and you have a documented history of opioid use disorder, you can begin to have treatment. And so we call it inducting or initiating people on medicine.
And then you now, through CODAC, follow them after, if they choose, right? So you don't just say, okay, great, you're out of prison. Now you can go back to your environment, and we're surprised that maybe they go back into opioid use disorder. But now you're providing the treatment afterwards as well, right?
That's actually a deliverable in our contract. And the third population that we had a huge amount of pushback in is, say, someone sentenced for 5 years and they're going to get out 90, 100 days from now. They start to have dreams, and your sister comes in and says, we're going to have such a big party for you and you're going to love the stuff out there now. It's crazy. And so it's all starting, and you can simply ask to be stabilized on a medicine before your release so that you don't have that risk. I think it's 147 times higher risk of overdose death for someone that is leaving the prison or jail across the country. 147 times higher than another person in the population.
So you mentioned that CODAC was the first in the nation with this medically assisted treatment in prisons. I'm assuming you learned a lot from that and you have a lot of other firsts. So could you describe some of those other things that you've done?
Most recently, we were the first mobile medical treatment unit to be allowed to dispense medicines for opioid use disorder.
So it's an RV.
It's an RV.
All right.
It's a 27-foot RV, and
that's a good size RV.
Yeah.
Because it's like going to a doctor's office, right? It's a mobile doctor's office.
It's a mobile doctor's office with a dispensary. So you can come in, you can get your buprenorphine, you can get your script, you can get your methadone. All of this can happen for you just like you would be going to a clinic for substance use disorder.
But you're going to the people that need it, right? That might not come to the doctor, so you're going to them.
And that is the second piece, the access issue. We need to be culturally congruent. We need to when we go into a community that is Spanish speaking or primarily Asian or primarily Black, whatever, we need to be culturally congruent because people need to feel respected and understood That's a critical piece of recovery, helping people engage in recovery. And so that's what we want. We want to take culturally congruent staffing into a community through a mobile treatment unit. And that's what we're doing here in Rhode Island, in Woonsocket right now.
Often Rhode Island is used as a test market to roll out products nationally. Is this a possibility that the mobile unit, especially I'm thinking of rural communities where they don't, Rhode Island's densely populated. You can, we don't like to drive more than 15 minutes anywhere, but when I'm thinking of people out west, I'm thinking about people that don't have that quick access to go see a doctor. Is this a possibility that it could serve them down the road, that being a mobile unit, it can go to them?
Absolutely, absolutely. And one of the goals for us, because even though Rhode Island is densely populated, it does not feel densely populated in Hope Valley. We need to decrease the number of people dying from this disease because it is treatable. It is so treatable. And so we need, what needs to be addressed? Access issues, which all of the access issues can be addressed by the flexibility of a mobile unit. We need to have safe utilization, harm reduction sites, that's critical. And we need to be able to have that culturally congruent sense of non-judgmental and we understand you feeling for people. So those three issues, those three methods by which to address this burgeoning death number, it works. The goal of that is to keep people alive until tomorrow. And we'll give you whatever you want to move towards recovery.
From Rhode Island's recovery leader, CODAC's mobile unit is on our streets. Our state's vulnerable populations now have access to more medical resources to better foster recovery through treatment. Leading our state's battle against opioid use disorder, CODAC is addressing the social determinants of healthcare by providing mobile medical services to communities most in need. To learn when and where CODAC's mobile unit will be in your community, visit CODACinc.org.
As CODAC has so frequently come to you for help, I would like to ask you today, is there anything we can do in the state of Rhode Island, as the Opioid Treatment Association of Rhode Island, as CODAC? Is there anything that you could use our help with?
Yeah, I think the most important thing for me is to have you succeed and then be able to lift up the example of your success to my colleagues, 4 other states, and then build national programs off of the success that you've shown. The recovery coaches that were involved in our emergency departments and that travel with police departments to engage with families who've had to have a police call. Those programs were very new when Rhode Island first rolled them out. And now they've gone broadly national. And I've been able to support a lot of that work because I can credibly go to colleagues and say, here's what happened in Rhode Island. Here's how this worked. And the police were skeptical the first year, but by the second year they loved it and you couldn't undo it with a crowbar if you wanted to. So I think success really breeds success, and the confidence of having a success gives legislators who aren't necessarily that close to the problem confidence about going forward.
So I know that you know that CODAC in Rhode Island has been, and fortunately so, it's been wonderful to be able to participate in anyway, but we have had a number of firsts in the nation in terms of finding successful, effective and efficient alternatives to what had been traditional care.
Yeah.
So, you referenced the peer recovery support specialists and the work with the police and the HOPE initiative, et cetera. We have also had the first medication-assisted treatment program in the country for corrections, who provides all FDA-approved medicines for everybody that needs them and for as long as they need them. I mean, I'm still giving consultation to groups where they only want to give one medicine that is the least effective of all. And that to me is, again, going back, like, how many times, how many years, how many decades do we need to keep saying this? So that's one piece that has definitely gone, I think, nationally at this point. I know it has. And also CODAC was the first medicating for opioid use disorder. Mobile unit. And it was the first in the country since the new DEA regs. And we're about to get the second one on the road. You can actually come to a ribbon cutting if you want. I don't know what you call it, but there's something that you call it when you start a new mobile vehicle. It's going to be a 35-footer. We're measuring with Brown University the efficacy and efficiency of that as well. But based on individual satisfaction, the folks that come to us for care at these different sites are thrilled with it because it works, because we know that access is a primary issue.
Well, part of the mantra of treatment is to reach people where they are, and that includes physically.
Yes.
So having the vehicles really makes a big difference. And then the work that Rhode Island did to prepare people in prison for release and set up the system upon release for them to continue to be supported in the community was a model for a lot of the work that I was able to get done nationally.
Good.
And I could make the case. This is how it worked in Rhode Island. And as you know, the most telling statistic was the massive drop in overdose deaths in that population, because that work had been properly done. And it was associated with lower recidivism as well. So it was win-win-win.
It was amazing. Anywhere, depending upon when the research was done, anywhere from 40 to 61% relative risk reduction for overdose death in the prison. And
now it's standard.
And that was in 18 months. When does that ever happen in medicine? It's so wonderful, right?
And now it's standard to start medication-assisted treatment before people are released from incarceration, to make sure that the support is there for them to continue it once they're released. Another Rhode Island victory.
Yes. Yeah, we and there's other things that are not necessarily related to the opioid epidemic, but they're connected. And that is, we also are very well known at this point in research areas for our hepatitis C program, the treatment of hepatitis C. And with the new medicines, we have 100% cure rate. I just love to say that, 100% cure rate. And then that leads people into, oh my goodness, I'm not going to die. So you know what, I don't want to use anymore. And we have a very high rate of people accessing our tobacco cessation program from the Hep C program, because they have this renewed hope. You know, true recovery. I'm going to live. You know, and it's just a wonderful thing.
No, it is a wonderful thing. And then we've done things like made the Firehouse program work better here than it did in the state which it was originally established.
Yep, I love that. It's a wonderful program, and it's spreading, which is really exciting.
And the folks who are working in the firehouses, the folks who are working in the police departments, are taking a look at this and seeing it as a really valuable solution that supports their effort to keep our communities safe, and not as an added burden or something that they don't think that they should be doing. The welcome, once the experience is there, has been also kind of a joyful thing to see. Well, thank you. I've learned a lot in being able to do my work in Washington from leaders in Rhode Island. I remember early conversations with dear Jim Gillen.
I know.
And then many with you. And we've had Rhode Island leaders go to Washington to run the SAMHSA program. So Rhode Island has a lot to be proud of.
Thank you. CODAC Healthcare today does what we refer to as fully integrated healthcare. course, we treat opioid use disorder and other substance use disorders. We do it with therapy, we do it with medicines. We provide primary care now. We provide psychiatric and mental health care. And as we move into our larger facilities with more capacity, we're going to also be able to provide all the social service networks in order to get their basic needs met.